So guys, we are talking about what? We are talking about the complications of spinal anesthesia. The intra-op complication, the most common is hypotension. The second most common is bradycardia. The third is shivering. The fourth is high spinal, and fifth is total spinal anesthesia. Total spinal anesthesia. So now after this high spinal and total spinal anesthesia, we have to discuss about the post-op complications of spinal anesthesia. We have to discuss about what, guys? The post-op complications of spinal anesthesia, right? So we have already written what is total spinal and all. Now coming to the post-op complications of spinal anesthesia. In the post-op complications, what we need to know, what is the most common post-operative complication of spinal anesthesia. Now guys, again with the case I'll let you know. We are talking about post-op. Post-op yani ke after operation. Again with the case I'll let you know how to remember this and all, and you can also remember. Now guys, I still remember I was being posted it was my 7th or 8th day of joining the anesthesia department, and my senior was giving spinal anesthesia to the patient. He told me to observe the things, and after he also gave me he also told me that after the surgery is done, you go to the patient and you ask the patient what is he complaining of. Okay, that patient was basically posted for this surgery, hydrocele surgery. Not hydrocele, guys. Not sorry. Not hydrocele. That patient was posted for diabetic foot surgery. For diabetic foot surgery, you go for spinal anesthesia. Okay. Now, guys, it can be done under ankle block and other blocks, but still you prefer spinal. Now, so the surgery was done. I went to the patient in the post-op period and I asked the patient, what is he complaining of? Is there any fresh complaint? The patient was telling that, doctor, I am having severe lower abdominal pain. I was confused. The surgery was of diabetic foot. Why is this guy having severe lower abdominal pain? I palpated his lower abdomen. What I found? I found that his bladder is distended. Why was his bladder distended, guys? Why was his urinary bladder distended? Why? Because remember, spinal anesthesia, when we give, the sacral segments are blocked. That leads to retention of urine. The most common post-op complication of spinal anesthesia was what? Urinary retention. But immediately what I did, as he was having this lower abdominal pain, I palpated his lower abdomen. I found out his bladder is distended. I did not ask my senior. I just took a Foley's catheter. I put a Foley's catheter and he was able to urinate a gush of urine, and his lower abdominal pain complaint was gone, right? From that day till this day, guys, in my practice, whenever I give spinal anesthesia or whenever I have been called for spinal anesthesia, I tell the nurse what? I tell the nurse that please keep a Foley's catheter, so that if you keep a Foley's catheter, we don't have this complication. We don't see this complication of retention of urine, right? So we are discussing about what? Post-operative complications of spinal anesthesia. The most common post-op complication of spinal anesthesia is what, guys? Urinary retention. Very, very, very important. It's the most common post-op complication of spinal anesthesia. Urinary retention. Urinary retention is the most common post-op complication. And you can easily manage, guys, by putting a Foley's catheter. Apart from urinary retention, we also need to know there are some other complications that can occur in spinal anesthesia. Headache can also occur. It is not the common. Headache is not common. And you guys know the reason why headache is not common. Why is headache not seen nowadays? Why? Because nowadays we are using what needle? Nowadays we are using a thin bore dura separating needle. If you use a thin bore dura separating needle, the patient won't have the complication of headache. But if you use a dura cutting or Quincke's needle, you will get to see this complication called as headache, right? So guys, remember, headache can be seen as a post-op complication, but it's not common. Which is the most common post-op complication? It is urinary retention. Headache. If at all headache occurs to a patient, again I'll give you a case. With that case, we'll learn about this headache. Imagine guys, you get a call from the hospital at 10 a.m. in the morning saying that there is a patient posted for LSCS, lower segment cesarean section. So you go to the hospital, and at 11 a.m. you reach the hospital and you give her spinal. But before giving, remember LSCS ke liye always you go for spinal. But before giving spinal, you prepare the emergency drug tray, right? And you tell the nurse to put a Foley's catheter so that emergency drug tray, intra-op complications can be managed. Foley's catheter if you put, the most common post-op complication can be easily managed. Now, before giving spinal anesthesia to this patient, now you are basically taking the needle. You see this needle, basically in this hospital they are having only Quincke's needle. Only Quincke's needle. You guys know what is Quincke's needle? Dura cutting needle. If you are having Dura cutting needle, you will get one thing in your mind that this patient will develop headache. So what you will tell, before giving spinal, you will tell the hospital management that please arrange some other needle. With this needle, the patient will have headache. But the hospital management is saying, sir, it's an emergency, sir. Please manage something. We can't arrange a new needle. So you are taking a Quincke's needle. You gave spinal anesthesia with a Quincke's needle. And on that day, you have done some 3 to 4 more cases. And you go back to your home. In the night at 2 a.m., you get a call from the same hospital. The nurse will be calling and telling that, doctor, today morning you have given us some spinal anesthesia to that lady, no? That lady is complaining of headache, right? So guys, what will you do at that time? First of all, you will get irritated that why are you receiving an emergency? Like in 2 a.m. is headache an emergency? You will be irritated, but still you have to respond. You will ask the nurse what? You will ask the nurse that, okay, she is having headache. I have used Dura cutting needle. There are chances, but still, I need to first confirm whether it is headache of spinal or not. Headache of spinal is called as post-dural puncture headache. So he will tell whether, first I will confirm whether it is PDPH or not. So how will he confirm? He asks the sister, when did the headache start? Remember, if it is a case of PDPH, the onset of headache will be 12 to 72 hours after the spinal anesthesia. How many hours, guys? 12 to 72 hours. Is that headache occurring after 12 to 72 hours? Yes or no? We gave at 11 a.m. At 2 a.m. in the night, we are getting the call, means already 12 hours are done. Yani it is falling under the criteria of PDPH. 50% your diagnosis is PDPH. Second, ask the nurse, where is the patient complaining of headache? The nurse will tell what? Doctor, the patient is complaining of headache in the occipital area, followed by bifrontal area. The most common site for headache to occur is in these two areas, occipital area followed by bifrontal. When these two things are matching, the onset as well as the site, 100% your diagnosis is what? PDPH. Remember guys, the onset of PDPH is 12 to 72 hours after spinal. It can persist for 7 to 10 days, but never persist more than 3 weeks, right? The most common site, again in MCQ, what is the most common site? Occipital followed by bifrontal. Now you will tell the nurse, yes, yes nurse, it is a case of PDPH. Yes sister, it is a case of PDPH. But it's not an emergency. Just give some conservative line of management or just give some coffee to the patient and don't unnecessarily call me in the night. So you have just advice for the coffee. You turn your phone into the silent mode and you will sleep. In the morning when you wake up, some 5 to 10 missed calls are there from the hospital. You get panicked. Why they have called so much times from the same hospital? You call back to the nurse. The nurse will be telling, sir, my night duty was very horrible due to this lady. She has created a nuisance over here due to her headache. Her headache is not responding to a mere coffee. Come to the hospital, give something to the patient. You go to the hospital. You go to the hospital. Inside the hospital, you greet the patient. Patient is looking very angrily on you. She'll be like, I'm having headache. I expect a good management from you. What is this coffee? Coffee can be given in home also. You tell her, madam, it is a case of PDPH. And the best management for PDPH is conservative line of management. She'll be more angry on you. Arey, what medical terms are you using? Conservative line of management. How will I come to know what is conservative? You tell her, in conservative line of management, first thing that we give is coffee, which I have already started. I have already started you on conservative line of management. Coffee I have already given. If after giving coffee also your headache doesn't subside, then we go for what, guys? If after giving coffee also the headache doesn't subside, then we go for what? NSAIDs. In conservative, the second thing that we go is NSAIDs. We give NSAIDs to the patient. If after giving NSAID also patient is telling, doctor, my pain is very, very severe, then you give what? Then you give, come on, then you give IV fluids. Then you give IV fluids. So remember guys, the best line of management for headache in spinal anesthesia is what? Conservative line of management. Conservative line of management. What do we give in the conservative line of management? The best, in conservative, we give coffee to the patient, we give NSAIDs to the patient, we give IV fluid to the patient. After giving a conservative line of management, 99% of the time symptoms are gone. Patient will be happy. But 1% of the time, some patients will be still complaining of headache. At that time, what will you do? Right? At that time, what will you do? First of all, guys, we are talking about what? Headache. Right? Headache. I told you headache usually onset is 12 to 72 hours. It can be there for 7 to 10 days, but never persists more than 3 weeks. The most common side we have already discussed, occipital followed by bifrontal area. Right? Nowadays, you don't see headache. Why? Because we are using dura separating needle. We are using dura separating needle. If at all the patient develops headache, the best line of management of headache is what, guys? What is the best line of management? The best line of management for headache is conservative line of management. It is a conservative line. In the conservative, we give first coffee, then we give NSAIDs, then we give IV fluids. If that also fails, the last option is what? Everyone look over here. Why did the patient had headache? Again, I am first drawing the dura. Beneath the dura is the arachnoid, and here is the subarachnoid space, which has what? The subarachnoid space has the subarachnoid space has the CSF. Right? Now guys, look over here. As we have used a dura cutting needle, there is much damage to the dura, and what has happened to the CSF? CSF got leaked. For this CSF, as the CSF got leaked, patient developed headache. That headache is called as post-dural puncture headache. If conservative line of management fails, what you need to tell to the patient? You need to explain that conservative line of management is failing, madam. We will go for epidural blood patch. Basically, guys, just look over here. You look over here, guys, look over here. The patient is having the hole inside the dura. That is that puncture inside the dura, and that puncture, due to this puncture, CSF is getting leaked. The main management should be what? If conservative fails, close this puncture. Close this puncture. How will you close this puncture? You can't close this puncture with your hands. Will you call a neurosurgeon to close this puncture? Actually, neurosurgeons are the ones who are working in the dura and all. Will you call a neurosurgeon to close this puncture? No. Why? Is it needed or not, guys? First of all, if neurosurgeon comes, he takes a large amount of money and all. But that's not an issue, guys. We're not calling neurosurgeon for that reason. We are not calling neurosurgeon. Why? Because it's not at all needed. You can also close this puncture. Now don't tell me, sir, we will only cut open the skin, we'll retract the vertebrae and go towards the dural puncture and close it. No. You can close this puncture dura by taking the patient's blood. You take patient's 5 to 10 ml of blood. How much? 5 to 10 ml of blood you take from the patient, and then what you need to do, guys? You take an epidural needle. You take what needle, guys? Epidural needle. Epidural needle, you take it from the, you take an epidural needle, right? And insert the epidural needle in the same space where you have given spinal. What is the space where you have given spinal? Imagine you have given spinal at L4 or L5 space, L4, L5 space. So what you need to do, take the epidural needle, insert the epidural needle at the L4, L5 space, but place it outside the dura. Place it outside the dura. You have taken some blood from the patient, no? Now inject that blood very, very, very slow, guys, so that it should clot and go. Inject the clotted blood very, very, very slow. You have to inject that blood through the epidural needle. What will happen, guys? That clotted blood will form a clot on the dura and closes the dura, closes the puncture of the dura. Hence, this is called as what? This is called as epidural blood patch. This is called as what, guys? Epidural blood patch. Is it the first option or the last option? It's always the last option. It's always the last option or last resort, right? If you close this puncture, will the patient have headache? No, sir. Why? Because there is no CSF leak and there is no headache. So guys, you close this puncture by placing an epidural blood clot on the punctured side of the dura, and this will be closed, right, guys? So remember, this is called as epidural blood patch. Is it the first or the last option? It's always the last option to be done in spinal anesthesia, to be done in post-dural puncture headache, right? So guys, remember, in post-dural puncture headache, the last option is epidural blood patch, where you take the patient's own blood and through the epidural needle, you insert that blood very slowly so that it forms a clot on the punctured dura. That is called as epidural blood patch. That is called as what, guys? Epidural blood patch. Okay? Now guys, we were talking about headache. Headache is not at all common. It's not at all common. If you use dura cutting, it will be common, right? The most common post-op complication of spinal is always urinary retention. Next is headache. And due to the headache, sometimes due to the loss of CSF, there might be a traction on the brain which might compress the sixth cranial nerve, and the sixth cranial nerve can be damaged, right? So the most common cranial nerve that could be damaged in spinal anesthesia is what, guys? What is the common cranial nerve to be damaged in spinal anesthesia? It is the sixth cranial nerve. Again, an important one, sixth cranial nerve. Sixth cranial nerve can be damaged in spinal anesthesia, right? Coming to the last complication. Last complication of spinal anesthesia is seen. We are talking about the last post-op complication. Last post-operative complication of spinal anesthesia is seen in patients. What patient, guys? It is seen, it's not the patient problem. It is basically the problem of the anesthetist. If the anesthetist is very lazy in cleaning the site, he is not cleaning the site properly. What will happen if you don't clean the site properly? The organism that is seen abundantly on skin is called as Staph aureus. You will take that Staph aureus into the spinal or the epidural space, leading to what abscess? Spinal or epidural abscess. Leading to what abscess, guys? Spinal or epidural abscess. Spinal or epidural abscess. Spinal or epidural abscess is also a complication of spinal anesthesia, which is caused by what organism? Which is caused by Staph aureus. Which is caused by Staph aureus. So this was regarding what anesthesia, guys? This was regarding the spinal anesthesia complications. Spinal anesthesia complications. Is this thing clear? Right. So, okay, those were the complications of spinal anesthesia, right? Complications of spinal anesthesia, intra-op complications and post-op complications. Now we will discuss about what? Contraindications of spinal anesthesia. In which patients is spinal anesthesia contraindicated? In which patients you never have to give spinal anesthesia? So the contraindications of spinal anesthesia include what? Contraindications. I'll give you through the cases, guys. Imagine there is a 20-year-old female diagnosed with ruptured ectopic pregnancy. Diagnosed with ruptured ectopic pregnancy. Okay. and the surgeon is telling that she will finish the surgery within 45 minutes. Which anesthesia will you give to this patient? What anesthesia will you give to this patient, guys? Remember, ruptured ectopic is below umbilicus. Below umbilicus, 2 to 3 hours of duration. Within 2 to 3 hours of duration, spinal. So it is done in 45 minutes. So best you go for what? Spinal. But ideally, spinal anesthesia is the answer that should come to your mind. But we have discussed that spinal anesthesia is given for below umbilicus short duration surgeries. But there are some exceptions. If one exception over here is what? Now remember, patient is having ectopic, but he is mentioning what ectopic? Ruptured ectopic. In ruptured ectopic, you know the hemodynamical stability of the patient is not there. The patient is not hemodynamically stable. In ruptured ectopic, the patient's blood pressure will be 70/40. Can you give spinal anesthesia to this lady? Yes or no? No. Spinal is contrained. Remember, spinal is given for below umbilicus short duration. But the exception, if the patient is in shock, I don't go for spinal, I'll go for general anesthesia, right? So remember, shock is a contraindication for spinal anesthesia. Shock is a contraindication for spinal. Why shock is a contraindication? Why? Because the most common complication, you guys remember, the most common complication of spinal is hypotension. If you give spinal to this lady, what will happen to the BP? The BP, which was 70/40, it becomes 40/20, or within no time it totally becomes 0, or circulatory collapse can happen. So that's why, guys, in shock, spinal is contraindicated. Even though below umbilicus short duration, but if the patient is in shock, spinal is contraindicated. The next contraindication of spinal anesthesia is patient having raised intracranial pressure. Raised intracranial pressure. Again, I'll give you a case. Imagine there is a 20-year-old male who's being diagnosed with appendicitis. 20-year-old male who's being diagnosed with appendicitis. Right? The surgeon is telling, I'll finish the surgery within 1 hour. And remember, surgeon is telling that he will finish the surgery within 1 hour duration. On taking the history, the patient is having underlying disease called as hydrocephalus. Now he's posted for appendicitis surgery, but underlying disease, what he's having? Hydrocephalus he's having. Will you give spinal anesthesia for this appendicitis patient who's having hydrocephalus? Yes or no? Hydrocephalus is not of concern over here. Appendicitis is of concern. That is a surgery that needs to be done. Will you give spinal anesthesia for this? If he was free from hydrocephalus, I would have given spinal. But if he is having hydrocephalus, spinal is contraindicated. Why? Why spinal is contraindicated? Why? Because in hydrocephalus, the intracranial pressure of the patient is very high. The intracranial pressure is high. In any patients whose intracranial pressure is high, if you give spinal anesthesia, the moment you puncture the arachnoid and go into the subarachnoid space, there will be CSF jetting out. You will see a jetting out of CSF. As the CSF jets out, what will happen? There will be much loss of CSF that can cause herniation of the meninges also. So, spinal contraindications we are discussing. First contraindication is shock. Second is raised intracranial pressure. Third, if there is local site infection. Local site infection. Meaning what? Imagine we are giving spinal anesthesia to the patient. We are giving spinal anesthesia to the patient in the sitting posture or any posture, okay? And this patient is having some abscess. Some abscess at what space? The patient is having abscess at the L3 to L5 space. Skin abscess at the L3 to L5 space. Will you give spinal anesthesia to the patient in this condition? No. Why? Why? Because if at all you push the needle through the abscess, then the needle will take the organism of the abscess into the CSF that can cause bacterial meningitis. That can cause what, guys? Bacterial meningitis. So local site infection is a contraindication for spinal anesthesia. Local site infection is a contraindication for spinal anesthesia. Next, if the patient is on bleeding, if the patient is having bleeding disorder, there also spinal anesthesia is contraindicated. If the patient is having bleeding disorder, there also spinal anesthesia is contraindicated. Why? Why? Because as you are introducing the needle from the skin to the subarachnoid space, there will be tiny blood vessels. Those tiny blood vessels can be damaged. In a normal patient, they will be damaged only. But after some times, if at all the blood vessels are damaged, the blood will clot also. The blood which is coming out from that blood vessels, it will clot also. But if the patient is having bleeding disorder, what will happen? The blood won't clot and the patient will develop what? Hematoma. Spinal hematoma can occur. So bleeding disorders means spinal is contraindicated. Shock means spinal is contraindicated. Why? Because the patient cannot tolerate this hypotension. Why? Because the most common complication of spinal is hypotension. Apart from shock, ischemic heart disease or any heart disease, spinal is contraindicated. Ischemic heart disease or any heart disease, spinal is contraindicated, such as severe valvular heart disease. Severe valvular heart disease means what? Mitral stenosis. Apart from that, patient having coarctation of aorta, HOCM. In all these conditions, spinal is highly contraindicated. If you give spinal to these patients, why it is contraindicated? Why? Because these patients cannot tolerate hypotension. These patients cannot tolerate hypotension. So remember, spinal is contraindicated in ischemic heart disease patient, यानी कि ischemic heart disease patient posted for hernia surgery, or heart disease patient, severe valvular heart disease patient posted for appendicitis surgery, यानी कि below umbilicus surgery, right? Below umbilicus surgery patient suffering with ischemic heart disease or any heart disease, spinal is contraindicated, right? Next, if the patient is refusing, last contraindication of spinal is what? Patient refusal. If the patient is telling, no doctor, I don't want spinal anesthesia, that's a contraindication. Don't force the patient for spinal anesthesia. You can tell the patient that spinal anesthesia is having many advantages over general and other anesthesia techniques. You can advise something for the patient, but you need to if at all the patient is telling that, doctor, I don't want spinal, means you don't have to go for spinal. Patient refusal is also a contraindication for spinal anesthesia, right? We have discussed all the contraindications of spinal anesthesia, guys. In which conditions is spinal not contraindicated? In which conditions you can give spinal easily without any contraindication? If the patient is having a blood pressure of 170/90 and the patient is having appendicitis. Appendicitis यानी कि below umbilicus, short duration, you can go for spinal. But how is the blood pressure? 170/90. Is spinal contraindicated? Yes or no? No, sir. Why? If at all I give spinal anesthesia to this patient, the patient's BP falls and becomes 120/70, becomes normal for some time. Yes or no? The spinal is not contraindicated in hypertension. Spinal is also not contraindicated if the patient is suffering with pre-existing neurological deficit. Meaning what? If the patient is having poliomyelitis and he is having appendicitis, you can go for spinal anesthesia. There is no problem. Okay, so that's regarding what anesthesia, guys. That's regarding what anesthesia. That's regarding the spinal anesthesia. That's regarding the spinal anesthesia. We know the complications. We know the procedure. We know the intra-op, post-op complications. We know the contraindications of spinal.